Well, greetings everyone, and welcome to the August 20th, 2012 EKG case of the week. And this week, we've got a case that was sent in from Chile, South America. First case coming in from South America, and this is courtesy of Dr. Pablo Fuensalida, in my best Spanish accent, reaching back to 7 years of Spanish back in middle school and high school. But hopefully I got that name right. And he is he's Associate Program Director at the Universidad Católica de Chile EM Residency Program. And he was nice enough to send a very, very interesting case. He was working out there in this particular program with some good friends at LA County Hospital from University of Southern California, Stuart Swadron, and Billy Mallon does some work down there also. And I think on this particular shift, he was working with Stuart Swadron, or Stuart was somewhere around there, and they happened to have this patient, 22-year-old man, that came in with brief syncopal episodes. Now, the quick story on this guy was that he had been doing some training, boxing perhaps, and was having some what was described as fainting episodes, and these were becoming more frequent, so he decided to come in to the emergency department and get checked out. Now, at the time of arrival, is completely asymptomatic, and his history and physical exam were pretty much non-diagnostic. He's got, for example, there's no family history of anything, and he's not using any drugs. There's no murmur or really any other abnormality, a healthy guy. And so what are you going to do? You're going to check a 12-lead EKG, and before we even get into that, I just briefly want to go back through what is it that you're looking for on the 12-lead EKG of a patient that comes in with syncope. Now, everybody always thinks about acute coronary syndrome and cardiac ischemia, and hopefully you think about Brady and tachydysrhythmias and AV blocks, but there's a handful of other things that you've always got to be on the search for whenever you see a 12-lead EKG of somebody coming in after syncope. You want to look for WPW, look for those short PRs and the delta waves. Look for Brugada syndrome. We did an entire segment on Brugada syndrome back, I think, March 4th, 2012. So if you want to review that, just scroll on back to the EKG cases from March 4th, 2012. Hypertrophic cardiomyopathy. Here's a young guy who's exercising and having these episodes. So certainly hypertrophic cardiomyopathy is going to rise to one of the top places in your differential. What are you looking for in hypertrophic cardiomyopathy? We talked about that just a few weeks ago, actually. High voltage and deep, narrow Qs, especially in those lateral leads, are very typical. You're going to look at the QT interval. Everybody knows about the long QT syndrome, and there's a bunch of things that can cause prolonged QT. We've talked about that as well. And just want to let you know that there is now a short QT syndrome. It's actually first time I saw it published was about 10 years ago, and I've been looking for short QT cases, and I think I've only come across one in the past 10 years, so I really don't lecture about this, but just be aware that there is a genetic condition that is now referred to as the short QT syndrome. Patients with extremely short QT intervals are also at high risk for sudden cardiac death. We're talking about QTC intervals that are less than 380, less than 350 milliseconds, so really short. And all the cases that I've read about are kids. Just be aware that it's out there, but it's fairly rare. And then another relatively rare entity is this arrhythmogenic right ventricular dysplasia. It's relatively rare in our population, but in certain countries and certain ethnic groups, it is a bit more common. And it's not that obvious on 12-lead EKG. What are you looking for on arrhythmogenic right ventricular dysplasia? I don't have any good cases to show you because this is another one that I've really been looking for and having a tough time coming up with good EKG cases. But in leads V1, V2, V3, what you're going to see is T-wave inversions, and oftentimes right at the end of that QRS complex, there's this little blip, and I'm exaggerating it just a little bit, but this is known as an epsilon wave, that little blip right after the QRS complex. I'm not the best drawer, by the way, but there's just a little blip right after the QRS complex, and flip T waves, V1, V2, V3, and Arrhythmogenic right ventricular dysplasia is not that common, and the EKG abnormality only shows up in about a third of this relatively uncommon condition. So I haven't really come across good cases that I can share with you, but it is one of the things to think about in your differential. These are the things you've always got to look for on that 12-lead EKG. Hammer this into your mind, and every time you check a 12-lead EKG, don't just look for these two things. A lot of people look for WPW also, but make sure that you're looking for Brugada, hypertrophic cardiomyopathy. Look at that QT and at least think about arrhythmogenic right ventricular dysplasia, especially if there's some type of family history and you're not seeing anything else obvious on the 12-lead EKG except T-wave inversions, V1, V2, V3, and perhaps those little epsilon waves. By the way, just as an aside, for arrhythmogenic right ventricular dysplasia, the diagnostic test of choice generally is a cardiac MRI. So it's not something that you're going to get immediately in the emergency department. It's probably more of an inpatient type of test. But anyway, let's move forward. What do? They got a 12-lead EKG, and here's part of the 12-lead. And you'll notice that the leads are oriented a little bit different than we're accustomed to, but leads 1, 2, 3, AVR, AVL, AVF, and then the rhythm stripped down there at the bottom. Well, while they're doing the 12-lead EKG, we're waiting for the precordial leads to come out. Boom, suddenly the patient loses consciousness and does this. So what do you do? What you notice, of course, is this is polymorphic ventricular tachycardia. Perhaps even it's torsade. We'll talk about what the difference is in just a moment. But what do you do when you've got a patient who suddenly goes into or presents with polymorphic ventricular tachycardia? Well, the first thing you need to do is decide, do I change my pants now or later? All right. So if the patient's got no pulse, probably best to do it a little bit later and use some air freshener in the meantime. If the person's got no pulse, is persistent, they're unconscious, you're going to have to shock the patient. And if you don't have those defibrillator pads ready right away, you're going to do CPR until you can charge up and you shock the patient. If shocking the patient doesn't work, you're going to give some magnesium IV. And I put slow push. When I say slow push, I'm really talking about over the course of probably 30 seconds to a minute. We're talking 2 to 4. Sometimes the literature says up to 6 grams. You don't want to push this in over 10 seconds because that's going to really cause a lot of vasodilation and make it more difficult to bring a blood pressure back. But probably 2 to 4 grams, I think, is generally what you're going to use if the shock doesn't work. 2 to 4 grams over about 30 to 60 seconds or so. And if that doesn't work, then you're going to try to use isoproterenol or pacing, overdrive pacing. And the theory is that if this is torsade and you speed up the heart rate, speed up the intrinsic heart rate with chemicals or with electricity, you're going to relatively shorten the QT interval. So that's the idea behind isoproterenol or the overdrive pacing. Fortunately, most of the time, those shocks do end up working. So that's what you're going to do. If it's persistent polymorphic VTAC, that person's going to be unconscious. You're going to need to shock them. All right. If it's intermittent polymorphic VTAC, then you might actually have a patient who's awake. If they're going in and out, in and out, in and out, the person might be awake, and rather than shocking, you might need to go ahead and use some drugs. So what drugs are going to use? Well, there's a difference here. If you're dealing with generic run-of-the-mill polymorphic VTAC, in other words, the QT interval, the QTC is normal, the drugs you're going to use are typical ventricular antidysrhythmics, amiodarone, procainamide, lidocaine. Most people are probably nowadays going with amiodarone. On the other hand, if during one of the episodes you're able to capture that QRS complex in the QT and the QT is long, then that is a special type of polymorphic VTAC that we refer to as torsade. Okay, so torsade and generic polymorphic VTAC are not the same thing. Generic polymorphic VTAC means you're looking at a normal QT, but if the QT is long, then it is the torsade type of polymorphic VTAC. That's how torsade is defined. Long QT, polymorphic VTAC. And in that scenario, the only drug you're going to give them is magnesium. You can't use amiodarone or procainamide, and probably not a good idea to use lidocaine either, because definitely amio and procainamide, perhaps lidocaine, are going to prolong the QT even more and make it even more difficult to get that patient out of Torsades. So that's kind of an important point in my opinion. If the QT is normal, that's generic polymorphic VTAC. Use whatever drug you want. If the QT is long, the only drug you're allowed to use is going to be that magnesium. Okay, so enough about that. And then after you convert them out of it, you get them back into sinus rhythm with shocks or drugs. You need to put them on something, some type of prophylactic infusion, depending on the QT. So after you get them out of it, if the QT is normal, you use one of these drugs. If you get them out of it and the QT is long, then put them on a magnesium infusion. And then very aggressively, don't forget about this, you want to search for and treat the underlying cause, because otherwise they might very well go right back into polymorphic VTAC or Torsades. Okay, so back to the case. The patient, after maybe less than a minute or so, actually spontaneously came out of it. I don't even think they had to do anything. This guy came out of polymorphic VTAC, and what do you know? What we see on his 12-lead EKG when he spontaneously converted, somebody was looking out for this guy because he spontaneously converted. And what you notice up here is he's got sinus tachycardia. He's still got a rapid rate, no surprise. And you notice in these V1, V2, V3, especially V1 and V2, he's got this very characteristic incomplete right bundle type of pattern with this coved or convex upwards ST segment elevation, right? So there's the QRS complex with that coved ST segment elevation and a slightly inverted T wave in V1, V2. And that, folks, is very, very typical and diagnostic of Brugada syndrome. And that's what this guy ended up having, Brugada syndrome. And so although we were saying before that after they come out of polymorphic VTAC, you ought to use a drug, in this particular case, what we know is that drugs don't work. Drugs do not work for Brugada syndrome. This patient needs an electrophysiologist to take him to the EP lab and put an AICD in this patient. That's the only consistently effective therapy that's been identified thus far. This guy needs an AICD. So, very interesting case. I want to thank the folks from Chile for sending that case. It gave us an opportunity to talk a little bit about polymorphic VTAC versus Torsades and about how the QT interval determines whether it's generic polymorphic VTAC or Torsades. I also always enjoy the opportunity to briefly talk about what type of things you should look for on the EKG of somebody in syncope. And also, it's always nice to get a little bit more practice and a little bit more visual experience at seeing that Brugada pattern in leads V1 and V2. For those people that are not, prior to today, familiar with Brugada syndrome, please review, I think, the March 4th EKG videocast, which was entirely focused on Brugada syndrome. You get a lot more information at that on that one. All right. So hope this case was helpful to you, and I look forward to talking to you next week. Once again, thanks to the folks down in Chile for sending this really interesting case. Talk to you next week.